Good morning. Good morning. So while you are finding your places and flocking in, we would like to start with another highlight of the meeting. These joint meetings with another society have become a tradition meanwhile, and I'm very proud to host this international symposium together with the French Society. And I really have to say that the collaboration with the French are extraordinary perfect. They have submitted abstracts. They are sitting here with me as a co-chair, and we have excellent speakers from the French Society. The presidents have shown up, so I'm really happy to present to you this international symposium, and I would like to introduce my co-chair, Cédric Barré, a very good friend, neurosurgeon, spine surgeon, and he will start to open the session.
Thank you so much, Peter. So good morning, everyone. My name is Cédric Barré. I work in Lyon at the University Hospital, and I am the vice president of the French Society. So we, the French delegation, with our president, Professor Patrick Tropiano, our past president, Dr. Jean-Luc Barra, are very honored and pleased to participate to this symposium organized by the German Society. We have so many connections with our German colleagues through the different European societies, the Eurospine, EINS, Cervical Spine Research Society, and so on. So it's really a great opportunity for sharing our view and ideas around spine surgery. So thank you so much to organize this session. Thank you to the program committee, thank you to the society, and thanks to the president, Peter. Okay, so we start the session. The first speaker is our past president, Dr. Jean-Luc Barra, working in Marseille, south of France. And the topic is MIS TLIF, my tips and tricks. Thank you, Jean-Luc.
Previous slide. Yes. Was it là? Next slide. No. Previous. Guten Tag, meine Damen und Herren. Im Namen des SFCR danke ich Ihnen für die Einladung zu Teilnahme an dieses Kongress. Und wir fühlen uns sehr geehrt, mit Ihnen über unsere Praktiken zu sprechen. So, the fashion effect and the assimilation of new technology can be an obstacle to embarking on minimal invasive surgery. Conversely, the benefit for the patient is undeniable, as well for the surgeon. The goal today is to show you that the obstacle is easy to overcome, and some tips are useful to be more serene. The enthusiasm for minimal invasive technique in spine surgery is tempered by the possibility and the anxiety of potential complications on their management. But the learning curve and technical innovation are also an obstacle for this development. The minimal invasive surgery is funny, is feeling like you find home, and surgeons like to use new technology. The evolution of number of publications in this field shows that there is an interest in developing this technique. Now, why minimal invasive surgery? The goal is to reduce tissue damage by achieving the same goals as open surgery. Do not increase the complication rate, and the indication remains the most important factor in the quality for the surgical result. Two approach is to be dilapidate, and why minimal invasive surgery? Less muscle decay, the increase of CPK in the spinal approach is significant and related to the wound, operating time, and revision surgery. After muscle retraction time more than 80 minutes, extensor muscle strength was reported to be only 50% of normal level 6 months after surgery. After open surgery, the MRI shows the muscle degeneration, and it is not necessary to retract all the muscle to do spine surgery. You can do the same without retract the muscle with minimal invasive surgery. The benefits are short-term benefits: less muscle decay, less bleeding, less post-operative pain, shorter hospitalization, WAC, faster recovery to the teacher's activity, and skin care. The long-term benefits is more questionable. Less low back pain with some questioning about the degradation of the adjacent level and the intervention. The last two remain to be demonstrated. And the techniques, the installation is fundamental. To limit the bleeding, we install our patient in GP position. The retractor is only an instrument, a tool. It must be allow a minimal incision and a large vision in depth. The incision, you can do a little incision of 3 centimeters to 35 millimeters the midline, and it's allowed to dilapid approach according to Wills. It's necessary to remain suspicion with the obese people. You have a sort of yogurt effect, and you can anticipate the incision line. You have to use all the means you dispose them to stay precise: microscope, fluoroscopy, CT, neuronavigation. At first, you use, after the incision, you use a candle to put the retractor on the walls of the vertebra. And the angulation of the retractor is fundamental. You must to stay in the axis of the pellicle. So, and you can see when you open the retractor, you can see a large vision in the depth. That is possible with a minimal incision to open 2 levels, 2 discs, or 3 vertebrae. So you can put intersomatic cage with osteosynthesis, 1 or 2 levels. And you can use, if you have osteoporotic bone, cemented screw. And you can reduce spondylolisthesis in a minimal invasive incision. With a good screw, it's quite easy. You can use your preferred cage, and there is no difficulty to put the cage. You can put the cage median anteriorly, like this. You can put the cage very anteriorly to have lordosis on the segment of the disc. So you can use bone grafting. You must to use bone grafting. You can take the bone in the posterior joint or iliac crest. You can put allograft. I use BMP of the graft inductors for the posterior lateral graft. you have a rapid consolidation. You must be careful with the BMP for exuberant bone, like you see here. You can see the bone posterolateral, and you can have a good bone around the word in posterolateral. They miss a lot of bone with BMP, and sometimes it's very, very bone construction, and sometimes with this one. This is BMP in the way of the retractor, and see its bone construction in this way. You must be care for this. And here you can see a lot of bone to the adjacent vertebra with BMP. Alors, my theory, 10 years, 850 patients. The complication, one surgical revision for spondylolisthesis in an obese woman with an anterior approach to reopen the patient with a screw rupture. 12 decompensation of adjacent stage, and the recovery, we can do an extension of the arthrodesis with the same MIS approach. Three screw repositioning, a total 16 surgical revival. Now, the complication of minimal invasive is one dural tear, no infection, 2 radiculate, is go with 2 weeks, it's got better. 3 screw malposition. You must care with minimal invasive incision of the angulation of the retractor. You must put the retractor in the axe of the pellicle, and you put the screw in the X. You can have tendency to put your screw too medianly, and so you have this. You must to put out the screw and to put a new screw. It's in the beginning of this surgery is the most problem of complication. So the learning curve is very fast, about 10 cases. Few complications, no infection, 1 breach, dural tear, no complication neurological. You have a shorter time, operating time, 68 minutes, a weak bleeding, 35 milliliters, no transfusion, and less irradiation. This technology is not in end in itself. It must help us to provide a better service to the patient, but in compliance with no rules and standard recommendations to obtain the best result. So, why you do MIS-TLIF? To respect the musculature, denervation, devascularization, muscle atrophy, loss of function, yes. To reduce post-operative pain, yes. To a faster functional recovery, yes. To limit the operative bleeding, yes. Limiting the perioperative morbidity and infection, yes. To limit the length of the hospitalization with WAC surgery, yes. And limiting the iatrogenic destabilization on the level adjacent, I don't know, veritably, probably. A little skin scare incision. And you can say with Connie Chapman, you know Connie Chapman, light is white. Light is white. And as more as spine surgeon begin incorporate this novel minimal invasive technique into practice, the field of minimal invasive surgery, spine surgery, will continue to innovate and evolve over coming years for the greatest benefits for the patient. Thank you.
Thank you so much, Jean-Luc. So I have a question. One limitation of the technique may be the restoration of the local lordosis, especially because you leave the midline structures, the spinous process, you leave the contralateral facet, hypertrophic facet, so it can limit the restoration of the local lordosis. So any tips to target the local lordosis?
Yes, you can remove the articular joints in the both sides, and you put the cage anteriorly on the lordotic cage, and you restore a lordose with a short segment. Yes, you can.
Any questions from the audience? So could you just briefly mention the role of navigation for your MIS practice? You use navigation or you think it helps you?
I use navigation with fluoroscopy, two-plan fluoroscopy. I think it's the better way. You have a CT, but the CT is more difficult to use today, every day. For short arthrodesis. When you use a long arthrodesis with scoliosis, CT scan is better. Yeah.
But for short construct, you use 3D imaging system
3D imaging,
with navigation?
Yes.
And just for the screws or also for the cage?
Only for the screw. Yes.
So thank you very much, Jean-Luc. As a sign of our appreciation, I have this one for you.
Thank you.
Thank you. So let's continue. The next presentation comes from Ralf Sobotke and his team, and he will report about our surgical activities during the COVID-19, and it's data from the registry, so it's really strong and high quality data. Looking forward to it. Thank you so much.
Bonjour, good morning, dear colleagues and dear colleagues from France. Thank you for the opportunity to speak. I've got no conflict of interest. Well, things changed 2020. We saw good things and some odd things as well. A good thing in my eyes was, well, except for medical stuff, the other employed tried home office with a very nice side effect, empty streets like holidays, like summer holiday, no traffic jam, no rush hour. On the other side, we had a desperate situation for the families because kindergartens and school were constantly closed. And having kids at home, so I speak from my experience, it was a blessing to have a garden at home. Well, we saw strange shopping habits. Well, you guys from France, you stored champagne, as I know, and things for a better life. Well, we in Germany, we panic buy toilet paper and noodles. We all experienced corona deniers and really bad, actually, a misunderstanding of science in public and in politics as well. So we have many gaps in many fields of life experienced with corona. And of course, it's the same in the surgery field. So I'll give you two examples, two papers out of that time, the beginning of 2020. The first one, which you can see here, is a survey among university professors of orthopedic and trauma departments in Germany. So this was an online survey which was done in the second week of April. And just to remember you, it was in the middle of March when the German government asked all clinics to postpone or even cancel their elective cases. So it resulted in a 50% reduction of OR capacity in German university hospitals. Next paper I would like to show you is coming from England. And these guys, they looked after their acute referrals to their spinal unit. And they did this for the time of February, March, and April 2020 and compared it with the time of 2019. And they found a reduction of referrals of 50% in the spinal unit. And they found a reduction of critical referrals, so critical spinal conditions. So 2/3 less infections and 1/3 less tumors. So we wanted to know what about the spinal surgery in Germany at that time. We therefore conducted this registry study and we analyzed the operative forms of the years 2019, 2020 and 2021. So we have a pre-pandemic group, 2019, and a pandemic group, 2020 and 2021. So just to give you an idea about the size of our registry, we now have about 800 active users, 150 active institutions putting their data into the registry. Over the years, we could collect over 300,000 operative forms, 26,000 follow-up forms, and 65,000 quality of life forms. This is the dashboard of the Robert Koch Institution in Germany, illustrating the waves of the pandemic in Germany over the years 2020 and 2021. Well, due to speech time and because each of these waves has its particular findings, we concentrate on the year 2020. First, just to ensure comparability, we had to find institutions which were constantly put their data into the registry in the years 19, 20 and 21. So we found these 96 institutions. My hospital is one of them. And all the data you see now is the data out of these 96 hospitals. Okay. In April 2020, we can see a significant drop of spinal surgical cases, and we see another drop in December. So this is the spinal surgery in general. But we have the opportunity to look after the pathology groups. So this is a bar diagram. And each bar diagram, each bar has a number, and the number is a reference to a pathology group. 1 is the degenerative group, 2, tumor, 3, inflammatory, like spinal infections, for example, 4, trauma, and 5, deformity. The bright blue bar is the data out of 2019, and the deep blue bar is the data out of 2020. So over the year, we could see that there is a moderate drop of cases in all pathology groups except tumor. In tumor, we even saw a slight rise in this year. So, but now what happened in the crucial months? Well, again, April 2020, time of lockdown. The hospitals, not all hospitals, but most or some hospitals followed the decree of the government and postponed and canceled their elective patients. So in this month, April, this is in the middle there, we can see a 34% drop of cases in the degenerative group, a 10% drop in tumor, 20 in inflammatory, 30 in the trauma group, and even 50% more in deformity. So we did this again in the second wave. On the right side, the bar diagram is December. This was the peak of the second wave. And again, we can see that there's a drop of cases in all pathology groups. But this time it is different. Well, we all know that the most elective patients are in degenerative and in deformity, of course, as well. But in December, in the second wave, it wasn't the degenerative group with the biggest loss. All the other groups, tumor, infection, fractures, had bigger losses than degenerative, which is quite interesting. So this now is a line diagram with a percentage change of the spinal surgery cases compared to 2019. In gray, you see the waves, first wave, second wave, third wave, and fourth wave over these years. And the lines are colored and referred to the particular pathology group. And again, this is very nice to see. In each of these pandemic waves, we see a clear drop of cases of spinal surgery in all pathology groups. But in none of these waves, degenerative had the biggest losses. In none of them. And another interesting finding is that we always have immediately after, well, I can't show it, but immediately after a wave, we see a compensation time, or in between the waves. The cases are rising again, much more than 2019. Two more further interesting things we found. In April and December, we had much less spinal surgery patients on ICU, quite understandable because they were overcrowded with corona patients. And this is impressive as well. We have a very clear left shifting of the inpatient time of spinal surgery patients. Well, to conclude, the pandemic is having a major impact on spinal surgery. In the waves of the pandemic, not only so-called elective cases were reduced, but also vital entities in particular. This problem did not only occur in the first wave, but even worse in the following waves. And this analysis of the German Spine Registry confirms the public and scientific statements about the undercare of patients, especially in the waves of the pandemic. So, special thanks to the guys of Relytics and my senior doctor, Anas Afifi. They were able to convert this data clouds, like this scatter diagram, into nice readable diagrams and made statistics understandable for us. Thank you very much.
Thank you, Rolf. Very good.
Thank you for the lecture.
Thanks.
So, from our side, in France, the situation was quite similar, especially during the COVID peak, and especially March, April 2020. There was a strong decrease of the activity, around 50 to 80%. Maybe the difference was there was really an impact of the pathology, and the trauma and tumor were more preserved, it was clear, but degen and deformities were strongly impacted. So according to the pathology, there was an important difference. And also, according to the region in France, so the East, Strasbourg, and the zone of Paris were mostly impacted, and less the west of France and the south of France. And according to the region, the difference could be very high. And the last point is the situation now. I would say that it's worse now than during the COVID period, because during the COVID, okay, there was the reduction during the peak of the COVID, but now it's a chronic situation in the hospital, and the activity is still decreased and reduced due to the lack of nurses in the hospital. So we are not returned to the normal activity.
That's right, and neither we do. Nothing is normal again now. We're still not balanced anymore. Yeah. Mm.
Rolf, thank you very much. Do you have any idea whether the delay in treatment of spinal oncology patients or infectious patients had any impact on neurological or overall outcome for these patients?
No, this is not. It's not something the registry can answer you. So it's just a personal impression I have, and I would say yes. Well, this is evidence level, very bad evidence level. It's just my opinion, you know. So evidence level 7, maybe, I don't know. But my experience was, I had several patients coming far too late with palsies and myelopathy. Well, I wondered why you come now. It's well, yeah. This is what my personal experience is about. So they have suffered because of the delayed referral to our clinic. Yes, they did. Same with tumor. It's not that impressive, but we have these cases, yeah. I have, if there's nobody who wants to ask me something, I ask myself something, okay?
It's okay.
Well,
Thank
I
you.
know because of a registry is something very special, you know, and the people are not really into this theme. So one question would be, what have we learned about this now? So, and I can tell you, well, we haven't learned much right up to the point now. We did the same mistake in all waves, but I found a very nice paper which I'd like to show you, which just was published in Lancet. This is an international working group, and they have performed an index, a so-called surgical preparedness index. So this is nice to read, and all your clinics can prepare for pandemics or other disasters by improve some points. Well, this is just I want to recommend to read. Okay.
Okay, thank you so much. So we have to move on. So the next topic is about adult spinal deformities by our president, Professor Patrick Tropiano from Marseille, about combined AP surgery to manage adult spinal deformities. So thank you, Patrick.
Hello, guten Tag. Thank you, Cedric. Thank you, Peter, to invite us. And the French team is very, very honored, and I enjoyed this meeting. Thank you so much for the invitation. I hope that it will be a new area where the relationship between France and Germany will increase. Yes, my combine will be on. My topic will be on combined surgery in the management of adult spine deformities. This is a disclosure of me and my team. Okay. Now everybody knows that adult deformity is not uncommon, and the indication of surgery is very variable with deformity. And estimation of the population involved in deformity is more than 60%. After 65 years old. The treatment is driven by disability of the patient. And you know that some values are related to disability. You see the alignment objective, this is what we call the French conspiracy, with the SVA less than 5 centimeters, the T1 tilt less than 0 degrees, the pelvic tilt less than 25 degrees, and the pelvic malleus lordosis less than 10 degrees. The strategy of the surgery is to restore the sagittal alignment. The tools, we know that are fusion, more or less osteotomies. And there is a big need for planning for the sagittal correction, but also to obtain a solid fusion. And this is the main problem of the patient. What about the strategy? The posterior strategy is well documented, and we know what to do when this kind of patient arrive. Do we have to do an anterior approach? It could be done. What kind of anterior approach we can do? There are two situations possible. The first one is anterior approach as an adjunct to fusion. We all know the fate of the risk of height risk of pseudoarthrosis in the L5-S1 region, and with the subsequent risk of road breakage. You see, the literature is very rich of this kind of information. L5-S1 ALIF in the management of adult spinal deformity has been done since many years nowadays in my department, and we're trying to do it in the first step or in the second time. It depends on the patient. The goal is to obtain a solid lumbar sacral fusion, whatever the strategy, just to minimize the risk of S1 loosening. Does it avoid the pelvic fixation? You know that when we put screws in S1, the risk for loosening is high with pullouts and failures. In case also in screws in S1, the risk of SI joint pain is increased. The screws in the iliac crest are less tolerated, and sometimes it's more difficult to join the screws and the rod. Finally, it seems that the screws in S2 ilium it could be the best option, and I know that Klaus Schneiker here is a specialist of this kind of screwing. Yeah, in our experience, we perform ALIF first in L5-S1 and sometimes in L4-L5. The posterior approach is done in second time, and it's better accepted by the patient if ALIF is done first than in second situation. Second situation, anterior approach is used for correction. Anterior correction of deformity is well known, and then we can do it and follow it by posterior fixation. You see in this case, we perform an ALIF on three level, and then perform a posterior fusion with a good reduction and a good stabilization of the spine. The most common procedure are the ALIF for L5-S1, more or less for 5. Sometimes OLIF or LALIF above L4. Like in this case, you see we did an ALIF in L5-S1 and OLIF on the level above until L1 with a good reduction and a shorter alignment on the posterior fixation. Sorry. There are theoretical advantages of the anterior correction. The larger surface for bone graft, of course, and more the L5-S1 lordotic effect with ALIF, because you see on the almost of the 2/3 of the lumbar lordosis is in L4 to S1. And then when you perform the correction in this level, you have a better effect on the lordotic correction than if you do it on the upper lordosis, even in high pelvic incidence. What about the literature about ALIF versus TLIF? For L4-S1, there is a comparable coronal curve correction. ALIF is superior on TLIF for the L4-S1 lordosis effect. TLIF, of course, is a shorter surgical time and hospitalization. But TLIF, but TLIF are associated with lower clinical scores and more, thank you so much, and more rod fractures. And what to compare anterior approach, open and miss posterior fixation. Comparison between LALIF plus open versus LALIF plus MIS gives similar clinical improvement. LALIF open gives better correction on COB, lordosis, SVA, and pelvic incidence minus lordosic. But LALIF plus MIS give less complication. You know, we developed a special protocol for anterior surgery with a planning with an anterior CT, an angio CT scan before the surgery. Now we are more than 1,000 CT scans done, and we observed various abnormalities. You see that kidney in pelvic position, kidney vena cava duplication, and many different sort of variable abnormalities. Probably it could be better to do angio MRI, but sometimes the images are less accurate than with the angio CT scan. In conclusion, anterior approach is interesting in the management of adult spine deformity. Different ways to use it as an adjunct or as a reduction tool. It depends on various parameters. Fusion includes L5-S1, L4-S1 lordosis, vascular anatomy, and surgeon skills. Thank you for your attention, and I invite you to come in Marseille for the next meeting of the French Spine Society in 2006. Thank you.
Thank you so much, Patrick. Any question from the audience? I have a question to start. So you mentioned the two strategies. So use the anterior approach just to reinforce the construct, to improve the fusion rates. And the other strategy was to make the correction with the anterior approach. So you use both strategies, and when do you go for one and when do you go for the other?
More of the time, when how do I say, if we correct only, if we need to make posterior osteotomies, in case to change the lordotic or something, we perform first L5-S1 fixation, just to reduce the amount of iliopelvic fixation. In case of only a lumbar lordotic deformity, then we perform first the correction with anterior approach and then posterior fixation. You know what I mean? In case of the adjunct for fixation, it's when we are in the situation of we perform a very huge technical for the posterior, just to reduce the amount of failure of the sacral fixation.
Okay, thank you. Yes? Question?
Yeah. Well, congratulations to very nice cases you presented to us. But I saw that in some of your cases you stopped at S1, probably relying on your anterior construct, which was screw augmented. So my question is, how do you deal with the problem of sacral insufficiency fracture? According to the literature, it's as high as 17%, and we see them once in a while, and often we tend to go to the ilium just to prevent that problem.
We don't have so many S1 fracture. We use the reason why we use the fusion, anterior fusion in 5-1, just to use only one screw in S1, just to decrease the amount of complication due to and we observe it with the fixation in with the anterior fixation of 5-1, we have less problem of loosening and fracture of S1.
Dr. Schnacke?
Patrick, two technical questions. First, what do you put into the cage to achieve fusion? Do you use iliac crest, bone substitutes, or do you use BMP?
I'm using BMP.
BMP.
Yeah.
And second, when you perform multi-level, ALIF, OLIF, whatever, do you position the patient in a supine position, in a lateral position? Do you change in between? So, from a technical point of view, because ALIF is clear, you go anteriorly, but what do you perform if you have a multi-level anterior fusion? So
I do the both. I do sometimes I'm doing on the anterior axis for the multi-level, and sometimes on lateral. And with lateral on L5-S1, I'm going until L1 bilateral approach.
And can you tell us the secret when to do what?
It depends. When obese patient, it's easier to go on the one way, and but personally, I prefer the ALIF than the lateral to do that, because it's better to manage with distraction. It's easier to reduce, and sometimes we use some. I would like to use asymmetric cages to reduce the deformity, but sometimes I'm trying to use the kind of cheap tips to reduce deformity.
So would you say that you have abandoned PSOs completely?
And I remember Klaus trained me on the S2 ilium screwing.
Patrick?
Do you remember Klaus?
Would you say you have abandoned PSOs? Would you say you have abandoned PSOs? You're doing the correction only from anterior? Or are there cases where you do also PSOs?
No, we do the both. Sometimes we need to have PSO or posterior osteotomy, and also anterior with the cage.
So when do you still rely on PSO? How much correction do you want to achieve?
It depends on the type of the deformity. If the deformity is just from L4 to S1, I think we can manage everything by anterior approach. If the deformity is upper, if we need to make more than 30 or 35 degrees of correction, it could be better to make an osteotomy on L3 or L4 and then make after an anterior approach.
There's another question.
Yes, if you aim for the lordotic correction by doing the anterior approach first, the two A-lifts, let's say from L4 to S1, do you sometimes find it a hindrance to have big facet joints on the back so that the back column might be an obstacle to the anterior approach and the lordotic correction first?
Sorry, what should we do?
And does it, do you observe the posterior column of the spine being an obstacle to the anterior approach for the ventral release by the two A-lifts?
Sometimes it's very, very tight, and you need to distract. But even when we remove, I did a lot of revision of T-leaf, pseudoarthrosis in T-leaf, and even with the screws, in the posterior screws, when you access by anterior, when you remove the cage and then you put your new cage, you can distract a little bit, and you can put the cage. And there is no concern with the posterior element, in fact.
Thank you.
Thank you.
So thank you very much, Patrick. Also for you, this document of appreciation. Thank you very much for your participation.
Thank you so much. Thank you.
And the next speaker comes from Neustadt, Sophie Thielemann. And she will report about the comparison of thoracic single curve versus double curve, adolescent idiopathic scoliosis in clinic, and also the German spine registry study.
Yeah. Dear Professor Baikotzi and dear Professor Barre, at first the co-authors and myself would like to thank the German Spine Society for the opportunity to present the results of this study. These are our disclosures. Professor Halm was part of the development team of both implant systems used in this study. The background of the study is that the majority of studies on surgical treatment on AIS focus on the radiographic outcome of surgery, which, however, does not always correlate with the patient satisfaction. Therefore, patient-related outcome measurements, so-called PROMs, should be included to evaluate the surgical outcome. In this prospective register study, AIS data were prospectively collected in a single scoliosis center based on the study design of the German Spine Society. Patients classified as lanky 1 or lanky 3 and 6 scoliosis curves who had a posterior spinal fusion between May 2019 and March 2021, and a minimum follow-up of 12 months were included. To classify the type of curve, standing long cassette radiographs using the EOS were taken preoperatively, postoperatively, and at follow-up. Additionally, bending films and traction X-ray were taken preoperatively to analyze the flexibility of the curve. So PROMs, clinical data, and radiological parameters were evaluated. And in total, we had 44 patients, of which 68% were classified as lanky 1, and 32% were classified as lanky 3 and 6. All of them had diagnostic images and SRS-30 questionnaires at each given time point. The mean age was 15 years, and the mean follow-up time was 17 months. The fusion length was longer for lanky 3 and 6, averaging 10.5, compared to lanky 1, averaging 8.5. The upper and lower instrumented vertebra were more distal for the Lenki 3 and 6 patients, T6 for the UIV and L4 for the LIV. The thoracic curve magnitude was fairly comparable for both groups without statistical significance. However, the lumbar curve magnitude was significantly higher for the Lenki 3 and 6 compared to the Lenki 1 patients. Correction parameters showed a significant beta correction for the thoracic curve for Lenki 1. And there was also a trend towards a better correction of the rotational deformity with a slightly better rib hump correction for Lenki 1 curves, however, not statistically significant. There was a comparable, for the correction of the lumbar curve, it was comparable for both groups without statistical significance. And in contrast to this finding, we noticed a significantly better correction for the C7 plump line, the LIV tilt, and the C7 deviation postoperatively. There was no statistically significant differences for the mean clavicle angle, the thoracic kyphosis, the lumbar lordosis, and the spinopelvic parameters. The SRS study questionnaire consists of 6 categories: pain, functional activity, self-image, satisfaction with treatment, the subtotal, and the total score. And the evaluation of the SRS study questionnaire showed a significant improvement for Lenki 1 curves in 2 out of these 6 categories: the mean total score, as we see here, and the self-image. Whereas function also improved for Lenki 1 curves, we noticed a slight deterioration for Lenki 3 and 6 curve fused down into the lower lumbar spine, however, not of statistically significance. So in summary, the results of the study show a good radiographic correction for Lenki 1 and Lenki 3 and 6, correlating with an improvement of the PROMs, specifically in terms of the self-image and the mean total score of the SRS 30 questionnaire. Lenki 1 curves, Lenki 1 patients also improved in the function. And in double major Lenki 3 and 6 curves, there is a slight deterioration of function, which is related to longer fusion levels into the lower lumbar spine. So our findings suggest that the PROMs should be included for a holistic evaluation of the surgical treatment on adult idiopathic scoliosis. The limitations of the study is that there was a small number of patients and a short term of follow-up with a mean of 17 months. But there was also a study published this year with the title 1 versus 2-year follow-up after posterior spinal fusion for AIS. What additional information was gained by Shaw et al. And they suggest that there are no significant changes between the 1 and the 2-year follow-up. Thank you.
Thank you so much for the presentation. So did this result change your way to manage these deformities?
Thank you for the question. Can you tell me once again?
Do the results of the studies change, modify the way that you manage the deformities?
No.
No?
Not.
Okay. Regarding the extent of the construct, or? No?
I don't.
I'm sorry. I'm the senior author of this study. What we change actually is, and actually this is also a trend among the surgeons of the scoliosis research societies, we try to look to stop the fusion at L3 wherever it is possible in Lenki 3 and 6 curves, because it makes a big difference if you have to go down to L4 or you can stop at L3, but this depends on the analysis of the bending films. You need a mobile disc at L3, 4 in order to, and you need to see a shift in the bending film of L3 into the center sacral vertical line. If this is given, we aim to stop at L3 in order to not to decrease the function of these lengthy 3 and 6 patients who need long fusions too much.
But in this study, did you look at the difference between stop at L3 and stop at L4?
No. The number is too small right now to look at that. This is just the first study within the spine registry of the German Spine Society, so the numbers and the follow-up is too short to make analysis on this topic.
Any other question or comment?
I have a question. I mean, this, especially the deformity module of the registry is also very intense in terms of data collection. So do you have any recommendations for the PROM analysis? Was it difficult, the compliance with the patients, the compliance with the surgeons, or are there any visions how to make this easier in order to really have a good compliance and data quality for the PROM collection?
I think it's just a matter of manpower. If the manpower is there, you have the people, you have a study nurse who looks after the patients, it is possible. They all agree to have the 1-year follow-up and the 2-year follow-up. And if you have somebody who looks after the patients, it's relatively easy. I know Ulf Liljenquist in Münster, he also has a study nurse and they also have their follow-up visits. And if you take care of your patients, it's possible, but it's mainly a matter of manpower.
Matter of mindset.
Okay, so we move on. Thank you so much. So next speaker couldn't attend the meeting, Dr. Delecrin. So we switch to the next speaker, Florian Ringel from Mainz, with a tumor topic and new technology and new materials for the treatment of spinal tumors.
So good morning, everybody. Thanks, Frederick, for the introduction. Thank you, Peter, for the invitation. Now, my title is New Implant Materials for the Treatment of Spinal Tumors, and what I'd like to do is to show you why I think that a radiolucent carbon or carbon-reinforced PEEK material is beneficial in the treatment of spinal tumors, and whether those implants fulfill all the criteria we're asking for a sufficient, stable instrumentation of the spine. There's one thing I need to disclose. This is the connection to Icotech. I did receive honoraria for a presentation in a lunch seminar previously, but I'm not receiving anything now. So looking at spinal tumor treatment, I'd like to refer to spinal metastasis primarily. This is a study showing you how spinal metastasis treatment changed within the recent 20 years and how the prognosis of those patients with spinal metastasis changes. And there's an improvement of survival for spinal metastasis from lung, breast, renal, and colon cancer by 40 to 100%. And this is a curve showing you lung cancer, where the survival increased by 100% within the recent 20 years. Though patients survive longer, patients will get local recurrences. And when we look at the local and marginal recurrence rate, which is the previously treated and marginal to the previous instrumentation, this is about 15% recurrence rate, and this does depend on the type of radiation treatment which is brought to the patient, whether this is a stereotactic radiation therapy, radiosurgery, or conventional external beam radiation therapy. So what we need to have if we want to pick up those recurrences, and when we want to have control of those patients, and when we want to have SBRT for the patients, SBRT planning, we need a very good high-quality local imaging for radiation planning and follow-up of those patients. And there we stand with our problem. When we use our standard titanium alloy implants, we get a lot of imaging artifacts, and we hamper high-quality imaging. And therefore, we need to look for alternatives. And one of the alternatives which came up in recent years are radiolucent implants. This is PEEK implants or carbon fiber reinforced PEEK implants for posterior instrumentation, which is stable enough to put those in those spinal tumor patients. Now, when looking at those implants, the question comes up whether this is sufficient for spinal stabilization in those tumor patients. Are they biomechanical equivalent to our standard titanium alloy implants? Is the intraoperative imaging during implantation sufficient to allow us for orientation for adequate implant placement? Is postoperative imaging really better than with standard titanium implants? Does it have a relevance for follow-up? Does it have a relevance for radiation planning? And how is the implant survival? Do they survive the patient survival time and are sufficiently stable? Now, looking at those points, first point is biomechanics. What do we know about biomechanics of those carbon fiber reinforced implants? And this is a study already some years old, looking at the stability of the posterior rods, carbon fiber reinforced rods, and what you can see in this study, there is no difference if you use a titanium rod or a carbon fiber reinforced rod. Those are sufficiently stable in comparison, those both the rods. When looking at the material fatigue, is there any material fatigue in comparison to titanium implants? No, there's not. Those implants as well in cyclic loading are as stable as titanium implants. There's no deficits, no fatigue of those implants, and especially they are at the upper limit of the implant or material resistant to cyclic loadings. Is there any difference in primary stability? And this is a study from the Schmelz group looking at the implants in a biomechanical lab, doing cyclic pulling on the implants which have been implanted in a cadaveric vertebra, and there's no difference between a titanium alloy implant and those carbon fiber reinforced pedicle screws in those cadaveric spinal bodies. Now this means biomechanically it seems to be sufficiently stable. Now how does imaging look? Do we really get a reduction of artifacts? Is there really a benefit of artifacts when using those carbon fiber radiolucent implants? And this is a study we did already some years ago. It was published 2017, looking at the first set of patients we treated with those carbon fiber implants, 35 patients, different spinal tumors, and we quantified the artifacts on CT images as well as on MRI, and these are the number of, or the volume of artifacts in CT imaging. What you see is there's quite a significant difference when you look at those carbon fiber implants in comparison to titanium implants. So there's a significant reduction of imaging artifacts, which means there's a possible benefit for long-term outcome and overall survival control. Now, when looking at the MR imaging, there's good or excellent imaging accessibility on 1.5 Tesla MRI and on the CT scans. But there's a problem when doing 3 Tesla MRIs, when you're using those implants which still have a titanium tulip at the end of the implant, and there's still a lot of artifacts in those 3 Tesla MRIs when using the standard carbon fiber reinforced implants coming from the titanium tulip of those implants. How could we improve this, as this is especially important for planning of SBRT for patients with spinal metastasis? And this is not a patient, don't worry, this is a cadaveric study where we looked at it, comparison of titanium alloy implants versus carbon fiber reinforced with titanium tulips versus complete carbon fiber implants, and we did 1.5 Tesla and 3 Tesla MR imaging. And what we found is that there is a significant advantage if you have a full carbon fiber implant in comparison to a carbon fiber plus titanium implant, regarding the visibility and the accessibility of the spinal canal, which is important for SBRT planning in those patients. And this has been shown by other groups as well, looking at the Phantom study from the Hamburg group, assessing the CT artifacts, where they found a significant reduction of CT artifacts, and as well when looking at MRI, there's a significant reduction of those artifacts. So what does it mean for intraoperative handling? Is it sufficiently visible, the screw, when implanting those screws? Yes, it does work. It needs some time to get used to it, looking only at the tulip and at the tantalum marker, which is in the tip of the screw. But these are images showing intraoperative radiation, and on the right side, an intraoperative 3D scan, where it's still possible to sufficiently visualize those screws according to the tantalum markers, which are implanted in the tip of the screw. When looking at post-op imaging, there's always the worry that we're potentially not going to pick up if there's any implant breakage, any screw breakage of those. But this shows you when you use your multiplanar reconstruction and CT scanning after surgery, you can nicely evaluate the carbon fiber parts of the implants, whether it's the thread of the screw or whether it's the rod. You can nicely control whether there's any breakage or any loosening of those implants, as well as in titanium implants. So, and finally, the question, is there any advantage for radiation therapy planning, for radiation therapy execution when using those implants? And the typical problems in radiation therapy planning with spinal implants is the intensity planning is changed. And this shows you how the diagram on the right side shows you the typical curve of photons with the blue curve and protons or particles with the green curve. When we look at the photons, if you have any material in there like titanium, you get an absorption of titanium and you get a potentially insufficient radiation therapy behind the implant. And when you look especially at the green curve, the proton or particle curve, you see that the release of energy from those particles can be completely changed. The area where it is released and the intensity of the radiation therapy can be completely changed by a titanium implant. So this is one problem of titanium implants in radiation planning. Another one is artifacts which make the spinal canal insufficiently visible for SBRT planning, and it is more time-consuming to plan with those artifacts in those patients. But is there a real advantage? And this is a study from the Munich group looking whether there is an advantage in the photon therapy and standard external beam photon therapy. There's probably not so much of a difference, but it does make a big difference when you look at particle therapy, when you look at proton or carbon ion therapy, which makes an important difference for primary tumor treatment. Now, finally, looking at implant survival, are those implants as stable as titanium alloy implants? And this is a study which we just started looking at our series of patients, 103 consecutive patients we treated in Mainz, looking at it in the follow-up until the final endpoint of those patients. And so far, we found 2 secondary implant failures, which is 2 screw loosenings, where one was an infection and the other one was an aseptic screw loosening, which occurred. So it's a small percentage of implant failure and a high number of implant survival. So in conclusion, those carbon fiber radiolucent implants are an alternative to titanium alloy implants in spinal tumors. They're biomechanically equivalent in the stabilization of the spine. The intraoperative imaging is sufficient during implantation. Post-op imaging is advantageous in comparison to the titanium implants. It does have a relevance for follow-up because we can follow those areas. We can look for local recurrences after radiation therapy. It does have a relevance for radiation planning, and we still have a sufficient implant survival. Thank you.
Thank you very much, Florian. Questions? I think there's another advantage that you have not yet mentioned. This is the picking up post-operative hematoma or other fluid collections. How is your experience with an early MR in the perioperative situation?
Well, this is what I showed in the MR imaging. This is with the standard now available implants, which still have the titanium tulip. There's a problem in the 3 Tesla imaging, but there's very good visibility in the 1.5 Tesla imaging. Though this is, as you mentioned, a benefit if you have a patient who has a secondary neurological deficit and you want to exclude an epidural hematoma.
Yes, I have a question about the capacity to bend the road. What about the contouring of the road? Is it possible or is it a limitation?
No, this is in fact a limitation. When you want to use the carbon fiber rod, carbon fiber PEEK rod, it's not bendable. There are straight rods and pre-bent rods which can be used for the standard contours. You still have the option to use it with the titanium rod, and the titanium rod is not so that problematic piece in 1.5 Tesla imaging. So it's still, the visibility is still good.
But you cannot modify the pre-bent rod?
The carbon PEEK rod is not modifiable.
Okay, good. I don't see more questions. So it's a pleasure to introduce and announce my co-chair, Cédric. And he will share his experiences with complex adult or angular deformities.
Thank you, Peter. So it's my great pleasure to share with you some cases about angular deformities in adults. So angular deformities may result from severe kyphoscoliosis, congenital abnormalities, post-traumatic or post-infectious diseases, or junctional iatrogenic kyphosis. So to prevent the complication associated with these deformities, the surgery is crucial and may require most often 3-column posterior wedge osteotomies. So let's see some challenging cases. So first is a male, 26 years old, originating from Guinea, presenting with a major thoracic curve on the right side, with a Cobb angle more than 110 degrees, the apex T5, T6, no neurodeficit. 3D CT scan showing the importance of the bony synostosis in the concavity, but no obvious congenital abnormality. There was no abnormal aspect on the cord on the MRI. So the case was treated very gradually, with first a period of halo-gravity traction for 1 week. Then first surgical step. So the first surgical step consisted of a posterior release with 4-5 level of rib resection in the concavity and ponte osteotomy, and also implantation of a rod in distraction in the concave side. And at this stage, the gain was around 25 degrees, as you can see on the radiograph. And finally, the second step, final correction, which was achieved with VCR at the apex. And you can see the cage on these intraoperative views, and the cage which is located not in front of the spinal cord, but lateral to it due to the scoliotic deformity. So at the end, the correction was satisfying, with a final Cobb angle around 42 degrees, corresponding to a mean correction of around 65%. And the result was maintained during time and during follow-up, and these are the control after 2 years. So optimal surgical treatment is still controversy to treat this rigid angular kyphoscoliosis. Pre-surgical traction is an attractive option to reduce the risk of neurological complication by leading to a progressive traction on the chronically compressed spinal cord. VCR is typically achieved at one level, at the apex, and is dramatically efficient, but technically demanding and risky in this context. Next case, congenital kyphosis. She is a female, 37 years old, presenting with a severe kyphosis, as you can see, at the thoracolumbar junction, with a Cobb angle more than 100 degrees, and sagittal angular ratio around 25, no neurodeficit at physical examination. You may observe the typical compensation and typical compensatory curves with lumbar hyperlordosis below and lordotic thoracic spine above. In this context, it can be useful to use some software and simulate the corrective surgery to determine the type and the amount of bony resection you need to achieve. So the case was treated by a combined surgery, PA-VCR, so first posteriorly with posterior VCR for correction of the kyphosis deformity, and in a second stage, anterior surgery just to reconstruct and reinforce the anterior colon. And at the end, nice correction, residual kyphosis around 40 degrees, 60% of correction, and most importantly, reharmonization of the profile, as you can see on the radiograph. So most congenital kyphosis result in severe angular sharp deformities. VCR permit, in general, to solve the problem in 1 or 2 steps. Large bony resection and the perfect control of spinal stability are the keys to reduce the risk of neurological complication. An alternative is represented by multi-stages procedure, which was proposed by some authors in one or different sequence. Let's move now to the lumbosacral junction. So he is a male, 36 years old, presenting with a medical history of lumbosacral arthrodesis, L4 sacrum, at the age of 21 in the context of isthmic spondylolisthesis and Scheuermann disease. He complained of chronic low back pain, walking disability, and L5 deficit. So these are the full span radiographs showing the instrumentation from L4 to sacrum, the global imbalance with C7 plumb line in front of the femoral heads, and the kyphosis at the lumbosacral segment, and also the retroverted pelvis. So SVA was around 200 millimeters. PI was high, 75 degrees, and only 14 degrees of lordosis between L4 and sacrum. And the CT scan confirmed that the deformity was completely rigid, and you can observe the lumbosacral segment completely fused with some huge bony bridges at the anterior part of the spine. Once again, in this context, simulation may be useful to analyze different surgical strategies and determine what should be the optimal site and optimal amount of osteotomy you need to achieve to target the correction. So finally, the case was treated with posterior sacral closing osteotomy, as you can see, with L2 iliac construct, and the surgery permitted to rebalance the patient with now C7 plumb line above the sacral plateau. This is a post-op CT scan showing the change in sagittal orientation of the lumbosacral segment and the effect of the sacral osteotomy, as you can see. And these are the results at 1 year with now the SVA returned to a normal range. PI decreased from 75 to 63 degrees, corresponding to a reduction around 16% of the pelvic incidence, which is more or less what is classically reported in the literature for that kind of osteotomy, and with good clinical outcome, as you can see with the pain and functional scores. So posterior sacral osteotomy is a nice option to treat this rigid fixed lumbosacral kyphosis. It permits to decrease the PI, changing the relation between the pelvic incidence and lumbar lordosis. Compared to pelvis opening Salter osteotomy, posterior sacral osteotomy is more powerful, as you can see with the formula, but more technically demanding. And finally, we go to the cervicothoracic junction with the last case. So he's a male, 54 years old, with a past medical history of ankylosing spondylitis, and also a history of neck injury 18 months ago. After trauma, he progressively developed a painful deformity in the cervical spine with a major disability, loss of horizontal gaze, as you can see. So this is the CT scan showing the post-traumatic kyphotic deformity at the cervicothoracic junction. The deformity was partially fused with some bony bridges at some places, and the kyphotic angulation was estimated to more than 50 degrees, around C7. So this is the patient in a standing position with the typical chin on chest deformity and the global kyphosis from cervical to pelvis. The posture was something similar to this animal bear. So obviously, all the postural parameters were strongly modified, C2 SVA, C2 tilt, and so on. So the plan was to go for a tricolon osteotomy at C7, so a kind of grade 6, according to Ames classification. So the deformity was clearly rigid, I confirm. So this is before surgery, and it was absolutely not possible to extend the head even under general anesthesia. These are the intraoperative view before and after reduction. So the reduction was achieved after VCR at C7 by external maneuver, moving very gradually the head in extension, and of course under intraoperative neuromonitoring. So you may observe the change after the surgery, and there is a big change in head position, and now possible to get contact between the occiput and the table. So these are the post-op radiographs showing the good correction of the deformity and the instrumentation from C2 to T5. Post-op CT scan confirming the good correction with the C61 segment now slightly lordotic, but with the presence of a gap, we may observe the intervertebral gap anteriorly, so additional anterior surgery was achieved to reinforce the anterior column, but it was done easily now after the correction of the head position, and at the end, a good correction of the kyphotic deformity. So finally, the patient was happy with the surgery, with recovery of the horizontal gaze and strong reduction of axial neck pain. So tricolon subtraction osteotomy is an effective technique to treat and correct this rigid kyphotic deformity at the cervicothoracic junction with, according to the literature, a mean angular correction between 20 to 35 degrees. The specificities at this zone are the large size of the spinal cord, the presence of functional roots involved in the hand motricity with limited space between the roots, and finally the small size of the C7 vertebral body, so limited the power of correction. Thank you for your attention.
Great cases, Cedric. The sacral osteotomy, which is quite nice for those procedures, but you always just put S2 screws below. That's a strong enough hold for you, or would you go for the iliac wing?
No, we put iliac screws. Okay. At least 2 iliac screws. Now we go for four iliac screws, so 2 each side, but no just S2. S2 is not enough. You at least iliac screws, yeah.
The 3-column osteotomies at the cervicothoracic junction, can you comment on the level? I mean, here you had the kyphotic deformity at C6, C7. So do you prefer T1, T2, or you always go for C7? What's the best risk profile for you?
When feasible, I prefer to go T1 or T2. Regarding the risk for the roots, you manipulate the roots. There is a relative high incidence of root deficit after that kind of surgery, around 10 to 15% in the literature. And of course, it's involved in the hand motricity, so it can result in a disability. So when it's possible, I prefer to go at the upper thoracic spine, T1, T2. But in this case, of course, the kyphosis was really at C7, so it makes sense to go for C7.
So thank you very much. I think we are running out of time, so let's discuss the other questions later on. And I would like to hand over your document here.
Okay, thank you so much.
And thank you very much for being such a reliable partner in organizing this symposium once again. So the next, last but not least, talk comes from Klaus-Dieter Schaase from Dresden. And he will give us some personal views on his experience on en bloc resections for tumors of the mobile spine and the sacrum.
Dear Chairman, thank you very much for the invitation. I also feel very privileged to be part of that international session here and to share our expertise and experience on this challenging topic of en bloc excisions of spinal and sacral tumors. Now, what's the clinical problem? The clinical problem in spinal and sacral tumors is that we have a close topographic anatomic relationship between the spinal cord and the essential neurovascular structures, aorta, cava, nerve roots, and so on. We have spinal cord compression, sometimes with dura adhesion and dura infiltration, and we have change in the malalignment, on the change in spinal alignment due to tumor growth, tumor destruction, which makes it even more complicated. And for the sacrum, it's a problem that we have a typically long asymptomatic intrapelvic tumor growth, and the patient typically present with advanced large intrapelvic tumor masses, which are then susceptible for a wide resection only less than 70%. Moreover, these high sacrectomies, which means a wide resection for the sacrum, in some cases is resulting in significant long-term morbidity with impaired bowel, urogenital, and ambulatory function. And this altogether makes it very difficult to attain oncological sufficient resections and increases the rate of negative, more positive margins and local recurrences and decreases survival and function. Now, if you look to the large registries we have with large patient numbers for these rare entities, there's strong evidence that surgical resection for chondrosarcomas for chordoma is the primary treatment of choice, as they are not responding to chemotherapy or radiation. The same for osteosarcoma and Ewing sarcoma. They, however, need to be combined with a neoadjuvant chemotherapy, as this is an independent predictor for survival. And it's also turning out that extralesional en bloc excision seems to be the best type of resection, as it prolongs progression-free survival. And this has been shown for chondrosarcoma, where the adequate resections are the most predicting thing for survival. It's shown for osteosarcoma, again, combined with chemotherapy. It's true for Ewing sarcoma, also in combination with chemotherapy and radiation, and also for chordoma, at least for the mobile spine, extralesional resection has a better outcome. And so it becomes true, and it becomes increasingly clear, it is clear that indicating adequate extralesional resection, so it's all about margins, every time it's about margins, is the most predictive prognostic factor for survival in that cases. Now, it's a historical merit of French surgeons to have performed the first extralesional en bloc excisions at the spine in the late 60s for a giant cell tumor of the spine. This technique was then refined and pioneered by Roy Camille, who has pioneered not only spine tumor surgery, but entire spine surgery. These are his historical images of his work, of his atlas. He performed a 2-level en bloc excision for chondrosarcoma for the first time and described the technique. Now, this technique typically entails, from the posterior approach, a simple long median approach, then you perform a costotraumaticectomy, a ripple section, and anterior release from the posterior using your gentle fingertips to detach the vessels, and then this followed by an insertion of a sigmoid-shaped hook to protect the vessels, and then you perform gentle with protection of the durasac discectomy, and then after laminectomy and discectomy and circumferential release, then you can turn out the specimen around the longitudinal axis of the spinal cord using the laminectomy gap as a corridor to pass out the durasac, and you have then en bloc excision of the vertebral body. This is strictly from posterior possible. In some cases, however, there are cases like that where I have a large extracompartmental tumor grows with encasement of the vessels. You can see that here, and you have also in the CT scan, the highest image you see there is a truncus. The truncus and the renal arteries are also encased. In such cases, you cannot do it simply from posterior. You need an additional anterior surgery first with preparation and resection and replacement of the vessels, in that case here, with debranching of all the organ arteries and reinserting them. It's a very challenging bypass surgery, and with that, during that surgery, you can also resect the discs from anterior also and cut the longitudinal ligaments and everything, paraspinous muscles, and then you can turn the patient and resect it from posterior. You can see here the view from posterior with the circumferential preparation of the spinal cord, screw rod construction, and vertebral body replacement is then done with a carbon cage. You see here, this is a specimen, negative margins all around. This is what we aimed for, and this is a reconstruction of the patient with the carbon composite cage and this function image after 3 months. Now, we have studied and published that in the past, and at my time at the charity hospital, and we have now looked at our data from Dresden in the last 5 to 6 years for all primary malignant and aggressive benign tumors of the thoracic lumbar spine and the sacrum, and also some selected cases of solitary metastatic diseases, as well as sacral infiltration of rectal carcinoma patients, which is a typical complication there. They all need to be scheduled for a curative treatment approach after board decision, of course, with indication for a mono or multi-level spondylectomy or partial or total sacrectomy. Now, these are the patient data for the mobile spine. There have been 32 patients operated. The mean age was about 50 years. Most of them have been sarcoma cases, chondrosarcomas, osteos, Ewings, some chordomas. They have only 5 patients with solitary mets included. All of them have been biologically favorable tumor entities like renal cell carcinoma, thyroid, and so on. Half of the patients received a neoadjuvant chemotherapy, the other half the neoadjuvant or adjuvant radiotherapy. For the sacrum, 28 patients, mean age 58 years old, 18 sarcoma cases and chordoma cases, 10 carcinoma cases. Most of them have been local recurrences of a pre-treated rectal carcinoma, and they all also have received in 15 of the patients neoadjuvant chemotherapy or immunotherapy and radiotherapy also for another 14 patients. Now, the results in surgery is that we had 16 multi-level excisions of the mobile spine, 3 of them cervical, 6 have been done with a posterior approach only, the rest with a combined anterior, anterior combined surgery. All the multi-level excisions received 3 levels above and 3 levels below fixed. The cage was, for the vertebral body reconstruction, a carbon composite cage was used, either modular or expandable. And we had a negative margins about 80% of the patients. The rest has been with a positive macroscopic margin. The follow-up rate was 90%. And for the sacrum, we had less cases, 28. Half of them, or 12 patients, have been operated with an intraoperative 3D navigation, CT-based navigation for planning the resection planes. 18 patients with a combined approach, 10 with only posterior approach. 10 patients received a total sacrectomy, another 10 a high sacrectomy at level S1 or below, and 8 patients in midline sagittal resection in terms of a hemisacrectomy. The sphenopelvic fixation was done in 14 patients. We do it nearly in every patient if we can do it. We may take an omentous Myers transfer from the abdomen for a dead space filling and a fram flap if it's radiation performed before. And also, we are very generous in the indication for a temporary colostoma because the infection rate is very high. We received a negative margin in 82% of the patients with a very high follow-up rate of 93%. Now, these are the oncological data. You see the disease-specific survival of the patient, which was for the mobile spine 15 months, and for the sacrum 67 months. And of course, much better data for the sarcoma than for the carcinoma patients. In this mobile spine group, 7 patients have been dead of disease, while in the sacrum cases, 4 patients are dead of disease. Now, for the progression-free survival, which means that there is not only the metastatic rate included, but also the local recurrences, you see that we had, despite we had negative margins in 23 patients. We have some cases who had a tumor recurrency, and for the sacrum this was shown that the data are much worse for the local infiltration of rectal carcinoma compared to sarcoma patients. And if you look at the metastatic free survival, you see that 43 or 44 months was a metastatic free survival for the mobile spine group, whereas the sacrum patients had similar or a little bit more, 47 months, the median metastatic free survival. And this again shows the difference for the sarcoma group compared to the carcinoma group, which has much inferior and worse results. Now, this is a case showing both and sacrectomy combined with an en bloc excision for an invertebrate body. This is a 27-year-old female, poor lady. She had a chondroblastic osteosarcoma. Initial diagnosis was made in 2017. She had chemotherapy done first, and the second-line chemotherapy, because of progression, she was considered not to be susceptible to surgery. Then she received proton therapy, immunotherapy, everything. She was progressing nevertheless. And you see here, these are the clinical image and the CT scan. They show MRI shows this extension to the SI joint, to the iliac wing, through the sacrum, in the spinal canal, to L5. And if you look to the CT scan, you see also there's extension in the inferior cava vein with a tumor, osteosclerotic tumor piece in the inferior vessels. And the PET still active, and the biopsy is still viable tumor cells. So what should we do? There was no radiation reserve, no chemotherapy anymore possible, so we performed anterior preparation first, resection of the vessels, replacement of the vessels, dissection of L5, L4 disc space, osteotomy of the iliac wing, preparation from anterior as much as we can, and the second day, you see here then the posterior preparation with en bloc excision of sacrum, L5, SI joint, and part of the iliac wing. This is then the resection piece with negative margins all around, including the vessel piece. And then this reconstruction was done with double rod reconstruction. And you see here the omentum majus, which take out to cover all the implants, which is very immunocompetent tissue. And then the fram flap was also harvested and used for soft tissue construction because it was radiation done before. This is a reconstruction thereafter, and she is walking with a walking frame because all the roots have been cut below L5, and including L5 on one side also. Shows she had a foot paralysis on the one side, but the soft tissue healed quite good. These are the images from before she left in the rehabilitation clinic, and she is now walking at home. Looking at the complication rate, we have a very high complication rate in both groups. Yet if you count every small wound revision, every dura leakage which had to be revised, everything that we had in the mobile spine group, 69% complication rate. I had to say that in all long-term survivors of multi-level excisions, we have a posterior hardware failure someday, in particular if it's done in the lumbar levels. And for the sacrum, we had wound revisions, I would say, in every patient with similar high complication rate, 79%. If you count every small revision of the wound and so on, we had also hematomas, urological complications, and we looked if these complications can be predicted by some parameters like near-adjuvant radiotherapy, or if navigation is helping to address that point, of the fram flap makes a difference or whatever. So we didn't find that. Maybe it's due to the small patient numbers, but the near-adjuvant radiotherapy seems to have a tendency, at least, to increase the rate for positive wound complication. How strange these complications can be should show at the end that case here. It's a 29-year-old patient, I think, with a clear cell sarcoma T12 L2, 3-level involvement, intraspinal extension. You see that paraspinal extension to the psoas, and we have then performed anterior preparation, posterior preparation with carbon rods, and peak expandable cage, and we resected everything. It was negative with negative margins, and the time showed that the Zagreb profile looked not too bad. But you see, however, if you look to the cage, you can see somehow the ring there. Then it's somehow dislocating. This becomes even more clear at the corona profile. You see that the cage is dislocating. Most likely it's broken. So our vascular surgeon was not very enthusiastic to go there again and to revise the cage, and I could not force him. So but we have to do something because one carbon rod was broken also, and so we performed a double rod reconstruction from the posterior part with double rods, and you see here then also in a fibula which was harvested and was transplanted there with vascularized. Everything was good, and you see also the fibula was perfused. However, in the follow-up images for the restaging, we saw that there's a covered aortic rupture, so there's an erosion of the dislocated cage to the aortic wall, and then the vascular surgeon was forced to do something. So I went again to him, and he then performed a segmental resection of the aorta with retrograde perfusion of the organ arteries here with a heart lung machine, and we put a new cage inside and replacement of the aorta, and this is in the patient thereafter. So I would like to summarize. For wide en bloc excisions at the sacrum and at the mobile spine, we need an exact staging and prognostic assessment of life expectancy and quality of life after surgery, and this determines our strategy. Many things are surgically feasible. We have to ask us if they are oncologically useful. These primary tumors and selected solitary lesions need a different therapy, en bloc excisions. However, we also need an improvement of systemic therapy, as many of these patients develop metastatic disease despite negative margins. They have a high perioperative complication rate, and we cannot expect diffusion, so hardware failure is predictable. Also, in particular in long-term survivors, we need to somehow do something in that case, in that patient. These patients belong to a spine tumor center for comprehensive multimodal therapy before biopsy, please, not perform biopsy. And we also need future studies to compare these surgical data to these promising data from SBRT, from high-dose hyperfractionated stereotactic body radiotherapy, which particularly for chordoma have promising results with lower morbidity, of course. Thank you very much for your attention.
So, impressive experience and great cases. I have a question about this kind of surgery for metastasis, because the benefit of en bloc surgery for metastasis is not so clear. We know that en bloc surgery is associated with high morbidity, and as you show, 70% of complication. But for metastasis, compared to gross total resection, the benefit of en bloc is not so clear. So what is your position about it?
This is always a very controversial topic, and if you're completely right. If you take all the solitary metastatic disease, there is no benefit of en bloc excision, at least for the overall survival. Maybe you have a better local control rate, but the overall survival is not better. However, if you look very detailed to the entities, if you look at all the renal cell carcinoma solitary ones or the thyroid carcinoma patients, they have a benefit of that. They also show some data for the spine shown that for these patients it could be some treatment of choice, but there's a study shown now for intralesional separation surgery combined with an SBRT compared to an en bloc group, and they have similar outcome with no difference in the overall survival, but a better control rate for local recurrences in the en bloc group. But our patients all have been renal cell carcinoma and thyroid gland cancer patients, so very selected ones.
Klaus, thank you very much. The field is always struggling with the different recurrence rates in the mobile spine and in the sacrum. In the sacrum, it always seems to be more difficult, and you always have like drop metastases in the gluteal muscles and so on. But however, it didn't really show up in your Kaplan curves of local recurrences. So would you confirm that the recurrence pattern in the sacrum is different? And is this a matter of biology, or is it a matter of surgical technique?
From my empirical evidence, I can only answer you. Its problem is with the sacrum that you have a high rate of chordoma there. And chordoma, they have a very strange growth into the obturatorous muscles and external muscle, and they have a high recurrency rate inherited in their tumor biology. Maybe this is the one thing why the recurrency rate is the sacrum higher. On the other hand, you can cut the roots, you can cut the spinal, the dural sac at S3 or S4, so you have not a problem with the dura compared to the mobile spine. But you are right, the the recurrency behavior differs at the sacrum compared to the mobile spine. And it's even more difficult in the cervical spine, with the vertebral arteries and all this.
And I have a technical question for sacrum location.
For sacrum, what?
Sacrum location.
Yeah.
Do you perform all the surgery from posterior, or do you perform anterior surgery first to release and then the posterior surgery? So
it strictly depends on the extension of the tumor and the initial tumor. If you have only S3, S4 involved, then you can do it from posterior, depending on the anterior tumor mass. Maybe you have a small sacrum part involved, but a large intrapelvic tumor mass, so you have to prepare the vessels. It depends on the tumor extension and on the tumor infiltration of the sacrum. I would say every high sacrectomy, or we always prefer to prepare the anterior first, release the vessels, cut the SI joint, take osteotomies there, so you have much easier job from posterior and much less dangerous. You feel better doing this.
Thank you.
So thank you very much, Klaus. Before Cedric is going to close the session, I would like to just raise your attention to this afternoon. We have one of our most outstanding German athletes and one of our outstanding abstracts. So I really ask you, it's a long day, but please bear with us, come to the session. There's 1.5 hours time to transfer to get ready for the social evening. So please stay with us, come to the meeting and pay attention to what's going on this afternoon here in this room. With this, I would like to conclude and hand over to Cedric.
Okay, so it was a pleasure to share this session with our German colleagues. We had very nice lectures, good discussion. So thank you to all of you for your presence and have a good meeting now. Thank you.